For the lecture, we gave you a case study, a case presentation of a young man, 29 years old male, who had certain signs and symptoms. Now, if you recall and if you go back and go through that case presentation, that patient presented to us. He had a history of ulcerative colitis, and then 3 years before, he had abnormal liver studies. And at that time, it was undiagnosed. And later on, he presented with certain signs and symptoms like jaundice and other symptomatology. And when the labs were performed, they had elevated ALP levels and elevated transamine levels. So now let's just go through the questions which we asked at the end of that case study to help you have a better understanding after you have gone through the whole lecture. Now, what were those findings suggestive of? As we talked about in this lecture, that primary sclerosing cholangitis has very strong association with ulcerative colitis. So that patient had a history of ulcerative colitis, and he did not have any other abnormality. He did not have a history of a liver disease. And when the labs were performed, they showed elevation of the ALP. Since there is elevation of the ALP, and we should have done GGT as well in that patient, that showed us an problem with the biliary tract. And since we know that the more common association of ulcerative colitis is with the primary sclerosing cholangitis, we should have raised a suspicion of that disease there and then. Afterwards, there was elevation of the transamine level as well. The bilirubin was normal in that patient, and it can happen in the early stages of the disease. So those findings were very much suggestive of primary sclerosing cholangitis. And then afterwards, we did a ERCP to find out the cause and to look at the biliary tract. And when we did an ERCP, we showed that there was dilatation and stenosis in alternating form. In some certain parts of the intrahepatic and the extrahepatic tree, there was stenosis, and in certain part there was dilatation, which was characteristically described as a beads on a string pattern. So there on ESCP, we were able to have a definitive diagnosis of primary sclerosing cholangitis in that patient. And just as we talked about in the diagnostic section of the lecture, or the imaging section, that imaging is the major definitive diagnostic modality to perform in the patients with primary sclerosing cholangitis. Now we have diagnosed that patient with a PSC. How will we manage this patient? Since this patient has an associative ulcerative colitis, it is very important to manage the ulcerative colitis. And as we talked about in the complications section, that the patients who have ulcerative colitis in association with PSC, they have an increased risk of colon cancer in them. And also there is an increased risk of cholangiocarcinoma and increased risk of gallbladder cancer. So it is important to have screening, colonoscopies, screening, MRIs of the abdomen performed to look and assess for these complications and their development. And if that patient develops these complications, then we have to do the serial tumor markers like CEA or CA 19.9, the other types of tumor markers to assess for the severity of the disease, and to do serial MRIs to look at whether the disease has progressed from its primary location or it has metastasized as well. Along with that, if we manage the symptomatology of the patient, if the patient has various types of pruritus, then we can manage it with the help of cholestyramine. To improve the bile flow, we can give a trial of ursodiol or ursodeoxycholic acid in that patient. If that patient develops cholangitis, then we can give him antibiotics to manage that. Eventually, since this is a young patient and he does not have any comorbidities, the curative treatment will be liver transplant. So if that patient can find a suitable donor, and if we have the compatibility, then liver transplantation can be very curative in this patient. And along with that, we have to manage the ulcerative colitis. We have to manage the ulcerative colitis before performing a liver transplant, because in a patient with an association with ulcerative colitis, these patients, even in transplanted liver, they can have a propensity to develop primary sclerosing cholangitis again. So with the help, by discussing all these relevant points, we are able to see how that patient is different from any other patient presenting with certain related pathologies, how we are going to differentiate them on the basis of imaging, and then how do we manage this patient. With that, we complete our discussion of primary sclerosing cholangitis. We went through all the aspects of this disorder in great detail, starting from the pathophysiology, the etiology, then looking at the clinical signs and symptoms, how are the complications going to develop, what are the major complications to look for, and then eventually what are the diagnostic modalities to rule out the various disorders and to confirm the diagnosis, and eventually how we are going to manage these patients. I hope you have learned something from this lecture, and I'm going to see you in another lecture.